Hi, everyone. We'll get started in a little bit. I'm just going to see if anybody else decides to come. All right, just a few more minutes and I'll see if anybody else shows up. All right, so I'm going to get started. So good afternoon, everyone. Thanks for coming to my CE. So my name is Michelle Kolakowski. I'm one of the pharmacy residents. And the title of my CE today is SGLT-2 inhibitors, a summary of the evidence. I chose this topic because throughout my residency so far, I've come across several clinical trials regarding the use of SGLT2 inhibitors and the benefits they have not only to improve glycemic control, but also in terms of cardiovascular and renal protection. So I just wanted to take this time to go over SGLT2 inhibitors and the studies that have been recently published to help everyone get a better understanding of the data and to discuss the potential future and place in therapy of SGLT2 inhibitors. Right now, we don't have any SGLT2 inhibitors on formulary, but it's possible that in the near future, this may change given these new findings that have been published. This is just my disclosure, so I have no financial interests or affiliations with any organizations. I do use some brand names, but that's just for identification purposes only. So for the objectives for today, we're going to define the mechanism of action and adverse effects of SGLT2 inhibitors, as well as describe the results from clinical trials that demonstrated cardiovascular benefit and explain the proposed mechanism behind these cardiovascular benefits associated with SGLT2 inhibitors. So before I begin, I just want to go over exactly what SGLT2 inhibitors are. So SGLT2 is an abbreviation for sodium glucose cotransporter 2 protein, and the SGLT2 inhibitors are a class of drugs that work by inhibiting this protein. I'll go over the exact mechanism in more depth in a few moments, but I just wanted to bring attention to the class of drugs that we're going to be discussing today. So you see some of the brand names that we have on here, but all the generic names, these drugs all end in gliflozin. So they're kind of easily identified through their generic name. So empagliflozin, canagliflozin, erdagliflozin, and dapagliflozin. And then the brand names are there for your reference as well. So we're just going to get into a little of the pathophysiology first. So just to give us a good understanding of exactly how SGLT2 inhibitors work, I just want to go over the function of the kidney first. So here on the left, I have an image of the kidneys. And as many of us know, the kidneys are going to work to filter blood and remove waste and extra water to make urine. And then the urine is going to flow from the kidneys to the bladder through the ureters and then ultimately excreted out of the body. And then within the kidneys, there's a network of nephrons, which I've shown one nephron here for you on the right. And then within each section of the nephron, there's going to be different fluid and electrolyte shifts that occur to ultimately create the optimal conditions for homeostasis. So just briefly, I just want to show you the different parts of the nephron, which are going to include the glomerulus, which is right there, the proximal convoluted tubule, the loop of Henle, the distal convoluted tubule, and then lastly, the collecting duct in which urine flows through and then goes to the ureters. So I'm just going to take a quick moment here and just jump in with a question. Does anybody know where SGLT2 inhibitors exert their action? If you just want to type it in the chat or unmute, feel free. Perfect. So I see some right answers. So yes, proximal convoluted tubule. So back to this diagram here. So just want to point out that's the proximal convoluted tubule. So right there is where the SGLT2 inhibitors are going to exert their action. So the proximal convoluted tubule is early on in the nephron and plays a major role in filtration and reabsorption of glucose. So about 180 grams of glucose are filtered each day by the glomerulus, and most of this is reabsorbed by the proximal convoluted tubule. So that's kind of why these drugs have their mechanism of action here. And here I have a closer view of exactly what occurs inside the proximal convoluted tubule. So on the left-hand side here, we have the filtrate, which contains sodium and glucose amongst a lot of other electrolytes. But I just want to point out that the green protein on the left-hand side of the membrane are the SGLT2 proteins, which are going to take the sodium and the glucose and transport it through the proximal tubule membrane. And then while inside this proximal tubule membrane, there is a secondary active transport process that's kind of required to provide energy to reabsorb the glucose in the blood. So on the bottom right of this image, I have the sodium potassium ATPase pump. And the sodium that was absorbed through the SGLT2 protein goes through the membrane and goes ultimately through this sodium potassium ATPase pump to provide the energy needed for another protein called GLUT2, which is on the top right of the image, which is going to transport the glucose back into the blood. So I just want to point out here that the SGLT2 proteins can only handle so much glucose. So as I mentioned in the last slide, the glomerulus filters about 180 grams of glucose per day. However, when levels exceed this amount, the SGLT2 proteins are going to become like saturated, and therefore you can't reabsorb the glucose. And this is when you're going to see glucose spilling into the urine, which is also known as glucoseuria, which is a key indicator of diabetes. So this is kind of like how the mechanism of how you see glucose spilling into the blood when levels exceed these 180 grams per day. And then here with this diagram, I kind of just want to tie together the pathophysiology and the mechanism of action of the SGLT2 inhibitors. So this is kind of a more simplified view of the nephron. And I just want to point out here that this image is actually reversed from the previous image I showed. So the glomerulus is actually going to be on the right-hand side now. So just keep note of that. So in normal physiology, glucose is going to enter this glomerulus, where it's first going to encounter this SGLT2 protein in the proximal tubule. And here we have about 90% of glucose reabsorption. And then when it proceeds through the proximal tubule, any excess glucose that's not reabsorbed by SGLT2 is going to be reabsorbed by another sodium glucose cotransport protein, which is known as SGLT1, which we have right here. So when a patient's on an SGLT2 inhibitor, that SGLT2 protein is going to be inhibited, and therefore you're going to block that 90% reabsorption, and then ultimately glucose is going to get excreted because it's not reabsorbed into the body. And ultimately, this is going to lower the overall plasma glucose in the body. And I just wanted to note here that this process is independent of insulin. Therefore, there is a lower risk of hypoglycemia when using these drugs, especially if they're used in monotherapy. And this is because the SGLT2 inhibitors only lower plasma glucose levels by blocking reabsorption of filtered glucose. And this filtered glucose is going to fall as like the plasma levels fall. So you won't reabsorb as much because they're not going to be filtering as much if your blood sugar levels are lower. So therefore, that's kind of why you don't see as much of a risk of hypoglycemia. But it is important to monitor patients on multiple diabetic medications as they can be more susceptible to hypoglycemia. And then another benefit of these SGLT2 inhibitors is that they promote weight loss because you're not reabsorbing that glucose. So it's kind of another added benefit of this medication. And so up to this point, I've been talking primarily about SGLT2 protein specifically. However, I did just mention that there is an SGLT1 protein within the proximal tubule as well. So we're probably more familiar with SGLT2 as we actually have drugs that specifically target this protein. But it is important to note that there is a difference and there is an SGLT1 protein. And this is going to be described in this chart, which I'm going to go over. So SGLT1 is essentially a low capacity, high affinity glucose cotransport protein. And like I mentioned, this mediates about like 5 to 10% of glucose reabsorption in the S3 or the distal segment of the proximal renal tubule. And then it's also important to note that SGLT1 is also found in skeletal muscles, heart, and is a primary mediator for glucose absorption in the small intestine. And I'm going to go a little bit more into detail that a little bit later in this presentation. And then as far as SGLT2 and how it compares to SGLT1, SGLT2 is a high capacity, low affinity glucose cotransport protein, which helps to reabsorb about 90 to 95% of glucose in the S1 and S2 segments of the proximal tubule. So these are going to work a little bit earlier in the pathway through the proximal tubule, which was demonstrated in that last diagram I had. And since SGLT1 is more distal in the proximal tubule, it does help with that renal glucose reabsorption that's going to evade the SGLT2 protein, either due to overload if there's too much glucose or if the SGLT protein is inhibited with an SGLT2 inhibitor. So it kind of picks up the slack, I guess, of what the SGLT2 doesn't reabsorb. And then I just want to point out that the primary reason that we have more drugs to target SGLT2 is going to be because of this absorption capacity. By inhibiting SGLT2, you're going to have more of an impact than you would if you were to inhibit SGLT1. And so that on that note, we're going to go into the specific SGLT2 inhibitors that are available on the market now. So I know that we went over the SGLT2 inhibitors that end in gliflozin. However, I just want to see if any of us can name some of the combination products that contain an SGLT2 inhibitor that are available on the market. Because there is a great number of them now, I wasn't aware when I first started this presentation how many combination products there were that had SGLT2 inhibitors. So if you know one, just type it in the chat. Oh, Farxiga. Well, Farxiga is a SGLT2 by itself, but combination is Zigduo. That's good. Thanks for the participation, guys. I love it. But we have some here. So we have Invocamet, which is canagliflozin with metformin, Glyxambi, which is empagliflozin and linagliptin, the Zigduo, which Sam mentioned, which has dapagliflozin and metformin, Qtern, which is dapagliflozin and saxagliptin, and Synjardy. So these are just a combination, just to like bring your attention that there is a lot of combination products now. And I'm going to go into this also in a second. Okay, so here I included the list of the available SGLT2 products with their brand and generic names for your reference. That's that chart on the left. And I just want to point out here that none of the SGLT2 inhibitors are available in the generic form as of yet. So it's just brand only for now. And then on the right here is a full table with all the SGLT2 inhibitors that are available in a combination product. So just to like kind of familiarize yourselves with those names and just to be aware that the SGLT2 inhibitors are often paired with different other diabetic medications. I was surprised about the combination products. So for example, I was just on the ID rotation, and we had a patient that came in, a diabetic patient who had a foot infection. And when we were discussing his medication list with him, he was on Zigduo, which he didn't know what was in the combination product, and the ID team was not familiar with this medication. They didn't know what was included. So they weren't really sure like how to assess his diabetes management because they weren't sure which medications he was on. So as the pharmacist, I was able to inform them what drugs was in this combination product and the mechanisms of action. So we can kind of really assess the patient and their diabetes control and so forward. So really this is just here just to bring your attention to the increasing number of combination products, and then just to be aware that of the mechanism of action, side effects, and risks if this ever arises along the way. And then on this slide here, I have dosing listed here for your reference. And then I just want to point out a few things here just quickly. So I have the initial dosing listed for each of the SGLT2 inhibitors. And then there is also a maximum daily dose. So basically if patients are able to tolerate the initial dose, and if they are able or they need additional glycemic control, you can go up to this maximum daily dose that's listed for each of those. And then all of the SGLT2 inhibitors are going to be contraindicated for use if a patient has an eGFR less than 30 mLs per minute per 1.72 meters squared, except canagliflozin. So this one's kind of unique. So just a little clinical pearl I just want to mention here. So if a patient has an eGFR less than 30, it's recommended that they're not initiated on this medication. So you should never start a patient on an SGLT2 inhibitor if they have an eGFR less than 30. However, with canagliflozin, it's recommended that if they have a urinary albumin excretion, so if they have albuminuria, basically greater than 300 milligrams per day, and they are already on canagliflozin, they can basically continue this medication even though they have a low eGFR. And then basically to assess a patient's urinary albumin excretion, you take the urinary albumin concentration in milligrams and divide that by the creatinine concentration in grams. So just a little clinical pearl just to keep in mind. And then the renal dosing otherwise is listed there for your reference. And then here I have a chart of the SGLT2 inhibitors and their labeled indications. And this I took straight from the package inserts. And this is going to be important just to note the differences between each of their products and their FDA labeled indication. So this is what differentiates these individual drugs within this drug class. So of course, each of the SGLT2 inhibitors are all going to be indicated to improve glycemic control, which I have listed here in the first column. Then if you notice, the second column is going to be an indication to reduce the risk of major adverse cardiovascular events or MACE events in adults with type 2 diabetes and established cardiovascular disease. So for this, we have canagliflozin, dapagliflozin, and empagliflozin. So those ones have proven cardiovascular benefit. And then I just want to note here that dapagliflozin also has an added indication for use in adults with heart failure with reduced ejection fraction, regardless of diabetes. So this was kind of, I'll get into this a little bit more when I talk about the clinical trial, but this is very unique that dapagliflozin, is indicated in patients with or without diabetes. And then lastly, in that last column, we have canagliflozin, which has another indication to reduce the risk of end-stage kidney disease in patients with type 2 diabetes. And then these indications were added to the medications after clinical trial results showed positive findings for these specific patient populations. And then I'm going to get into those clinical trials in just a few minutes. So now I just want to touch on the side effects and warnings associated with the use of SGLT2 inhibitors. So we have the most common side effects listed as genital mycotic infections and urinary tract infections. And this is going to be due to the mechanism of action we went over previously. So the glucoseurea provides an optimal environment for bacteria to grow and cause infection. And since patients with diabetes are already at an increased risk of infection due to the decrease in immunity associated with diabetes, they're kind of more at risk for this, especially with the combination of the SGLT2 inhibitor. So another common side effect is going to be the increased risk of bone fractures. This side effect is a little bit controversial, as some studies have shown the increased risk of bone fractures, while others didn't appear to show that SGLT2 inhibitors affect bone health. But the warning is still listed for this class of medication, so it is recommended to assess patients' risk for fracture prior to initiation, just a clinical assessment. And then I also have listed here the risk of diabetic ketoacidosis associated with the use of SGLT2 inhibitors. And basically earlier this year, in March of 2020, the FDA released a statement regarding the risk of DKA with SGLT2 inhibitor use. And basically it was found that patients on SGLT2 inhibitors presented with ketoacidosis in a unique way, like they have normal or modestly elevated blood glucose levels. So not like typically sky high glucose levels you typically see. And this risk of DKA may be in part due to the mechanism of action. So the increased urination may cause an increased risk of dehydration in these patients. So therefore it could like worsen or precipitate DKA. And then with this FDA warning, there was new recommendations to stop SGLT2 inhibitors prior to like a scheduled surgery. I have it listed here that canagliflozin, dapagliflozin, and empagliflozin should be stopped at least 3 days before scheduled surgery. And then erdagliflozin should be stopped at least 4 days prior to scheduled surgery. And basically this kind of comes down to the risk for DKA is kind of higher when patients get surgery. Basically due to like inconsistencies with blood sugar management prior to and after surgery. So if a patient's told like not to eat before surgery or not taking insulin prior to surgery, and then other factors like the anesthesia itself, surgical stress, dehydration, and then the risk of post-operative infection can all like precipitate DKA. So that's why this risk is there with the underlying already risk of increased DKA with these medications. And then one other side effect I just want to talk about is the increased risk of amputation. So there is a US box warning, or there was a US box warning on canagliflozin or Invokana for the risk of leg and foot amputations. However, recently on August 26th of 2020, the FDA released an update to the prescribing information to remove the black box warning for amputation. So in early clinical trials, there was a finding that canagliflozin was associated with a higher risk of amputation than placebo. However, with this FDA update, the FDA stated that information from more recent clinical trials suggests that the risk of amputation is still increased with canagliflozin, but it's lower than previously described, particularly when patients are appropriately monitored. So although they removed the boxed warning for amputation, it's still recommended to recognize the importance of preventative foot care measures, monitor for new pain, tenderness, sores, and just proper diabetic foot care management. Okay, and then here I have a slide about the place in therapy. So the use of SGLT2 inhibitors for diabetes has a well-known and accepted indication of recently. So here I have, it might be a little blurry, but here's an image from the American Diabetes Association Standards of Care 2020 Diabetes Guidelines. And SGLT2 inhibitors, specifically those with proven cardiovascular benefit, are the preferred treatment after metformin. So here I just have highlighted. So basically metformin's first line for everybody, but if patients do have like established ASCVD, CKD, or heart failure, the ADA guidelines are going to recommend SGLT2 inhibitors for these patients. And the ADA guidelines define SGLT2 inhibitors with proven cardiovascular benefit as those that have labeled indications of reducing cardiovascular events. So that's kind of why I went over the labeled indications. So just to recall, we mentioned that canagliflozin, empagliflozin, and dapagliflozin specifically have these labeled indications to reduce cardiovascular events. So I just wanted to bring this to your attention just to be aware of where the diabetes guidelines recommends SGLT2 inhibitors now. And then, like we discussed earlier, there are two SGLT proteins, so SGLT2 and SGLT1. So I mentioned that the role of SGLT2 inhibitors is well known and accepted, but is there a place for an SGLT1 inhibitor? Would combining SGLT2 and SGLT1 inhibition improve outcomes? So these are kind of the questions that are being talked about now. So there are several SGLT1 inhibitors that are in the research phase. However, there is one that's currently undergoing review by the FDA currently. It's called sotagliflozin. And there are some clinical trials that were recently published. So of November 2020, these two studies in the New England Journal of Medicine were published, and they both had really positive outcomes that found that patients with diabetes that were started on sotagliflozin had decreased a lower risk of composite deaths from cardiovascular causes, hospitalizations for heart failure, and urgent visits for heart failure than placebo. So this is just like a quick little, keep your eye out for this potential of this drug, which has that dual SGLT1 and SGLT2 inhibition. It's called sotagliflozin. So more to come with this in the future. Okay, so now I'm just going to get into some of the clinical trials and the important findings from these trials. So here I have a timeline showing you when the studies involving SGLT2 inhibitors were published, and I kind of color coordinated them here for your reference. So those that are in red are going to be cardiovascular outcome trials. And then the trials in green are going to be heart failure trials. And then the two that are in purple are going to be chronic kidney disease trials. So I'm not going to go over all of the trials, but I just included them here for completeness sake. And then I also included here some of the trials that are in the works. So studies that are currently being investigated but not yet published. So we have one, the DELIVER trial in 2021, and then EMPA kidney, which is 2022. I'm going to go into those a little bit more towards the end. And then I just included this timeline here because it gives a good visualization of how the trends of the studies are evolving and these new indications are being looked at. So first, I'm going to just start with the EMPA-REG trial, which is a cardiovascular trial. And then with each of these trials, I'm just going to highlight some of the key inclusion criteria of the study, as well as the clinical endpoints and just some key takeaways. Oh my God, sorry, I can't speak, from each of the studies. So first here we have EMPA-REG, which I mentioned, and this trial looked at empagliflozin versus placebo in a primary composite outcome of death from cardiovascular causes, non-fatal myocardial infarction, or non-fatal stroke. These are also known as MACE, so major adverse cardiovascular events. And going forward, I'm just going to refer to it as MACE because it's a little simpler. And just to go over the patients that were included in this study. So this study included patients 18 years of age and older with type 2 diabetes, and the patients had already established cardiovascular disease. So you'll come to see with each of these trials, they are very similar in nature, but there's slight differences in the patients that were included in the study. So those are going to be some of the things I highlight. So now getting into the results from the EMPA-REG study. So this study found that empagliflozin showed statistically significant reduction in death from cardiovascular causes, which was the primary outcome. I have shown here in the top left graph here, this one. That's the primary outcome. And then I also highlighted here that it was statistically significant in this chart here. So that is a composite outcome. So it's also important to note that with composite outcomes, you also want to look at each component individually from that composite outcome. So I highlighted here also death from any cause and death from cardiovascular causes as also being statistically significant. So this kind of boosts your confidence in the results of the composite outcome. And then lastly here, I just have on the very bottom of that chart highlighted hospitalizations for heart failure was statistically significant and was reduced with empagliflozin. So this was a secondary outcome, but this is going to be like a key outcome, and it's going to kind of be seen in the trials going forward. So this is just one of the good benefits of this trial. And so then next we have the CANVAS trial. So the CANVAS trial is actually going to be two sister clinical trials, CANVAS and CANVAS-R. And these trials looked at canagliflozin versus placebo with the same primary outcome as the last trial, which is going to be that composite MACE cardiovascular events. And then these patients were a little different. So they were a little bit older, so 30 years of age and older with established cardiovascular disease, or they could be 50 years of age and older with 2 or more risk factors for cardiovascular disease. So they had kind of a different patient population, but all patients did have a diagnosis of diabetes, and they were also required to have an eGFR greater than 30. And then here from the primary outcome, those MACE events was statistically significant in that canagliflozin has shown to be better than placebo in reducing these cardiovascular deaths. And then just as with the EMPA-REG trial, the components of death from cardiovascular outcomes was statistically significant on its own. So if you see that I highlighted here, so death from cardiovascular causes was also statistically significant. So that kind of boosts your reliability of the composite outcomes. You can kind of take that better. And then also here, this one also found, the CANVAS trial also found that hospitalizations for heart failure was statistically significantly reduced with the use of canagliflozin. And then on the right here, I just highlighted this amputation risk as well, because like I mentioned before with that black box warning with canagliflozin, this is where that original box warning came from, because there was a statistically significant increased risk of amputation with this drug. So then we have next the DECLARE-TIMI trial. This trial was another cardiovascular outcome trial that looked at dapagliflozin versus placebo with the same primary outcome of major cardiovascular events. This trial was unique in that it had a second primary outcome, which is a little different than the other trials we talked about so far. So this second primary outcome looked at a composite of cardiovascular death or hospitalization from heart failure. So like I mentioned, this was done basically because during the time this trial was going on, the EMPA-REG results were published, and it showed those robust results for the reduction in hospitalization for heart failure. So this trial decided to add that onto their study as well to see if they could reproduce those same results. So these patient populations, these were patients 40 years of age and older with type 2 diabetes and established cardiovascular disease, or they had multiple risk factors for cardiovascular disease. So they included both kinds of patients, patients with established or just risk factors for cardiovascular disease. And all patients had diabetes in these trials. So the first primary outcome, so the reduction of those MACE, those major cardiovascular events, was not statistically significant with the dapagliflozin group compared to placebo. However, that second primary outcome of cardiovascular death or hospitalization for heart failure was statistically significant. So that second outcome that they had there. And this secondary outcome was another composite. So looking at that hospitalization for heart failure independently also was statistically significant. So that was kind of that driving force, which also shows benefit here. And then lastly, for the cardiovascular outcome trials, we have the VERTIS-CV trial, which looked at erdagliflozin versus placebo and the primary outcome of those MACE events. And then this patient population was kind of similar, patients 40 years of age and older with established cardiovascular disease and diabetes. And then this trial is going to be unique because this trial showed non-inferiority to placebo. So I have that highlighted here. So for non-inferiority. So it did not demonstrate superiority to placebo in reducing those major cardiovascular events. So this is important because like we mentioned with those labeled indications, erdagliflozin was the only SGLT-2 inhibitor without an indication for reducing cardiovascular events in patients with type 2 diabetes. So this trial tested that hypothesis that it would reduce cardiovascular events, and it didn't hold true. So therefore you can't imply those results, and it did not get that added indication. So just a unique thing to point out that not all of them have shown cardiovascular benefit. However, I just want to point out with this graph on the right here that erdagliflozin did have a pretty good reduction benefit in reducing death from renal causes. That was like a secondary outcome that they looked at here, and you see it's statistically significant as well. So now we're just going to touch upon the studies that looked at SGLT-2 inhibitors in heart failure, which is kind of came out of those first few trials where they showed the reduction in heart failure. So that kind of was the basis for these next few trials. So basically it's shown that patients with diabetes have a much greater risk of developing heart failure than patients without diabetes. And then some of these proposed mechanisms are going to include hyperglycemia leading to ischemic myopathy and cardiac hypertrophy through direct impact on the heart. So basically diabetes is just going to have a negative impact on the heart, which can lead to heart failure. So first we have the DAPA-HF trial. And this is basically going to look at dapagliflozin versus placebo. And this primary outcome is going to be different than the ones we talked about because it's going to be focused more on heart failure. So it was a composite of worsening heart failure or death from cardiovascular causes, which were secondary outcomes in the other trials we just mentioned, but this is their primary focus. And then it's unique to talk about the patient population in this trial because these patients did not require a diagnosis of diabetes, but they did accept patients with or without diabetes. So patients were 18 years of age and older with an ejection fraction of 40% or less. So basically they had heart failure with reduced ejection fraction. And they were also required to have NYHA class 2 through 4 symptoms. Just some other inclusion criteria include an eGFR greater than 30 and an NT-proBNP level of at least 600 or 900. So basically this is more heart failure focused and less diabetes focused. And the results of the study found that among patients with heart failure with reduced ejection fraction, the risk of worsening heart failure or death from cardiovascular causes was lower among those who received dapagliflozin than those who received placebo, regardless of the presence or absence of diabetes. So this kind of is the basis for why dapagliflozin has that added indication for use in reduction of cardiovascular events in patients with or without diabetes because of this trial. Because this was kind of like a landmark trial. If you see both of the primary, the components of the primary outcome were also statistically significant. So this one was a very groundbreaking trial that these SGLT-2 inhibitors could be used in patients without diabetes as well. And then lastly, we have the Emperor Reduced trial. So basically this just very similar to the DAPA-HF trial. It's just going to look at empagliflozin versus placebo. For those same cardiovascular death or hospitalizations for heart failure. Same thing here, patients did not have to have diabetes. They just had to be 18 years of age and older with CHF, with reduced ejection fraction, and an eGFR cutoff a little bit lower at 20 mLs per minute for this patient population. And then the results of this trial also found that empagliflozin had a lower risk of cardiovascular death or hospitalization for heart failure than in the placebo group, regardless of the presence or absence of diabetes. So I just include here, this was also, since this is a composite outcomes trial, this is one of the components of that composite, and it was also statistically significant, adding more robust reliability of the results. So now I'm just going to quickly touch upon the trials that are currently in the works and that are going to be published soon, just to see where these trials are heading. So first we have the Emperor Preserve trial. This is basically just piggybacking off that Emperor Reduced trial that I just mentioned. And basically it's looking at the safety and efficacy of empagliflozin in patients with preserved ejection fraction. So basically they had great results for the patients with reduced ejection fraction. So now they just want to test its efficacy in patients with preserved ejection fraction. And this is going to be estimated to be completed April 15th, 2021. So just be on the lookout for this trial. And then next we have the Deliver trial. So this is going to essentially be the same thing as the DAPA-HF kind of too. So this is going to look at dapagliflozin versus placebo in terms of like in the addition of standard of care and reducing the composite endpoints of cardiovascular death or heart failure events. So very similar to the DAPA-HF trial as well. And this is also scheduled to be completed in later 2021. And then we have EMPA-KIDNEY. So this study is going to investigate the effect of empagliflozin on kidney disease progression or cardiovascular death versus placebo on top of standard of care in patients with pre-existing chronic kidney disease. And this is not going to be completed until late 2022. So I just want to take a second and just tie everything together. So as we went through all the trials, in the early first few trials, it was primarily focused on those cardiovascular benefits in patients with diabetes. So if you notice when I first started talking, it was all patients that had diabetes. And then through these trials, they kind of saw not only the cardiovascular benefit, but they saw this reduction in hospitalizations for heart failure. So those next middle studies kind of honed in on that heart failure benefit, and they wanted to see if patients with or without diabetes would see the same benefit in reduction of heart failure. And then throughout all of the studies, they kind of have seen a renal protective effect of all these SGLT2 inhibitors. So now that's the next step with these newer studies as well. They're kind of looking on the effect of chronic kidney disease protection and in patients with or without diabetes. So basically they're all piggybacking off of each other and taking what they're finding in one study and making new studies out of it. And so how exactly do these SGLT2 inhibitors have all these cardiovascular benefits that are being demonstrated in these trials? So this is a bit of a busy diagram, but I think it does a good job of explaining some of the potential or the proposed mechanisms of cardiovascular protection. So some of the main ways that SGLT2 inhibitors impact cardiovascular outcomes is through weight loss and blood pressure reduction, because essentially it's going to act like a diuretic, has like a diuretic effect. And then some of these other proposed mechanisms are going to include decreasing preload, decreasing afterload, and decreasing overall effects in the myocardium, such as decreasing hypertrophy and cardiac remodeling. So basically overall has a lot of effects on the heart that are protective. And then here are some of the proposed mechanisms for renal protection. And since this hasn't really had good studies yet, it's kind of still unclear of how they have the renal protection, but some of the proposed mechanisms include the decreasing blood pressure overall helping the kidney, decreasing intraglomerular pressure, decreased albuminuria, and then decreasing renal ischemic injury, which all lead to a preserved renal function. So this is going to be further investigated with, I'm assuming, that EMPA-KIDNEY trial as well. So we'll see if those renal protective effects are seen in that trial. And basically, I just kind of want to take a minute and just discuss with you some things here. So given all of these benefits that are demonstrated with the SGLT2 inhibitors, I just want to see what the audience thinks about, do you think SGLT2 inhibitors should be added to formulary? We don't have any on right now, so if you do you think one would be better than the other? Should we have all of them? I just want to see what the audience's thoughts are on this. Seems like we should have something, yes. So it is a kind of a controversial debate. Right now, the American Diabetes Guidelines do not recommend SGLT2 inhibitors for inpatient hospital use, but maybe with these new trial findings, that could be updated in the next update. Yes, it is very interesting because we don't use oral meds inpatient, and that is because of the risk of hypoglycemia, and they think the ADA guidelines kind of want just insulin-only therapy for patients acutely ill that are inpatient. But these trials overall have all found such good benefits, especially started early in patients. So I'm just kind of curious to see if other hospitals will do the same or if things will change in the near future. And then another follow-up question. So if added to formulary, do you think it should be restricted to a specific patient population? Should we have like a consult service? Like should, you know, nephrology be involved or endocrinology? It's like so many people involved because of the cardiovascular. Should be cardio or renal, diabetes. Yes to consults. Yeah, because I think everybody might prescribe, and with the EGFR cutoffs and stuff, I think it's going to be important to have like specific consults. I agree. Thanks for everyone's participation. And then lastly, I just have a thing here. Do you think SGLT2 inhibitors will be added to heart failure guidelines? Just an audience, I have no idea, but yeah, I think I agree. Yes, I think with the benefits it's shown and how significantly it's reduced like hospitalizations and deaths from heart failure, I do think it's going to be coming in the near future to keep an eye out with SGLT2 inhibitors added to the guidelines. Thanks everyone for your participation. That was great. And then just to like kind of wrap things up here too. So with the new SGLT2 inhibitors on the market and so many of them with compelling evidence, which do you choose? Like which is the best? So based on the studies, it's important to take into account your specific patient and which study criteria are best matches your patient. So you want to look at their age, their comorbidities. Do they have a diagnosis of diabetes? Do they have chronic kidney disease? What about heart failure? And kind of seeing which trial showed the best results for that patient population. Also looking at their renal function. Some of them have different EGFR cutoffs. And then at this point, sometimes it may come down just to simply insurance coverage. As you've seen and as I've discussed, like the outcomes are pretty consistent across the board with these SGLT2 inhibitors. So finding out which SGLT2 is on a patient's formulary, if any of them are, is what it might come down to. And then also looking at that side effect profile. So they do mostly have the same side effects, but as we discussed earlier, canagliflozin did have a higher risk of amputation compared to the other SGLT2 inhibitors. So that might be a consideration as well. If a patient has a history of amputations, canagliflozin might not be the best choice. So just some things going forward. And then here we have in summary. So basically I went over the mechanism of action, blocking glucose reabsorption in the kidney, and then increasing that glucose urea, which has been proven benefit in patients with diabetes. With these new trials, we do have benefit cardiovascularly and renally in patients with or without diabetes. And then further studies are being conducted to evaluate these benefits and potential finding for a new role of medication for these medications in other guidelines and not just the ADA guidelines. And any questions? Thank you everyone for your participation. Thanks. Thank you. I have the post-assessment questions. I'm going to email them to everybody with this new Zoom only. I'm just going to email everybody the question. If you could just email me the answers back just to get credit, and then I'll email the CE code. I think that's what we're doing going forward now. If anyone has any questions, or if I'm not saying that right, I think that's what. Yeah. Oh, he said just email me. Yeah, Caesar said just email me. I'll email everyone the questions that was here, and then just email me back, and then I'll email you with the CE code. Sorry. Thanks, everyone.